I think I played this for you before. This is one of my family's all-time favorite songs. The Kinks' Better Things. We'll get to the PowerPoint quickly here. Let's cut the Kinks. Okay, let's get on to the PowerPoint. This PowerPoint is called Biomedical Therapies. Here's kind of an overview. There are three types of biomedical therapies you should be aware of, and you should know what they are now before I click on them. Some sort of medication or taking a pill, some sort of electricity, ECT, electroconvulsive therapy, and then some sort of kind of cutting in or surgery. There are emerging techniques that the book talks about, and I'll briefly go over, that involve either some kind of pulse like electricity or magnetic stuff. I'm going to do a little bit on the history. The bulk of this will be on the drug therapy and the four main types of drug treatments, a little bit on ECT, a little bit on surgery. That's it. In terms of history, for most of human history, it's bad. You know from the book that 1793, you get Philippe Pinel in a few years after the French Revolution has started, unchains the patients, and it gets a little bit better in the beginning of asylums, but it's not much better. The next big change is in the 30s with the development of frontal lobotomies for about 20 years, but again, that's not much better either. The 50s is really the beginning of drug therapy and with the introduction of antipsychotics, and that's a revolution. Things get much better with the use of drugs, and at the beginning there's not much of an understanding of why they work or how they work, but they do sort of work. They're better, and you come to today where there's a recognition that some combination of drug therapy and other forms or forms of psychotherapy are really the best method that we have to date in terms of treating disorders. So let me talk a little bit about psychopharmacology. The big picture would be that there's a benefit of drug therapy in that they control symptoms and are often really necessary in getting symptoms under control. But you have to keep in mind that drugs are working on neurotransmitters, and that those are obviously fundamental in the way every nerve cell communicates with another, and so drugs have a widespread action. They're acting throughout the brain and the nervous system, and so there are widespread effects and lots of side effects. So while they are effective, they have this broad spectrum of effects that needs to be taken into account and used with care. Should review agonist and antagonist. An agonist is a type of molecule that will mimic or enhance the effect of a neurotransmitter. So you should review this if you need to. It's not as simple as a drug that acts like a neurotransmitter and mimics it, so increases the amount of it. It can work in very subtle ways, like the SSRIs. And the antagonist is not the same thing as just blocking it. It blocks or reduces the effect. So understand that there are lots of different ways that agonists and antagonists can work, and it's not as simple as mimicking or blocking. That is an electron micrograph of an actual neuron. It's been opened up at the synapse or the axon terminal to reveal the neurotransmitter, or the synaptic vesicles. So those orange and blue things are vesicles containing thousands of neurotransmitters inside each one. Okay, what were the major disorders? Without looking, can you try to recall what were the major disorders we talked about in the previous unit? Because you're going to want to match up disorders with types of therapies. So there were the anxiety disorders, depression, and bipolar, excuse me. Then the disorders having to do with thought disturbance, so dissociative and schizophrenia. And then, of course, the personality disorders. So what you want to be able to do is think, okay, which one of those have drug therapies? And to a certain extent, they all do. But obviously, the anxiety disorders are going to have anti-anxiety drugs. The depressive disorders are going to have antidepressants. The psychotic associated disorders, primarily schizophrenia, are going to have antipsychotics, and then you're going to have medications to treat bipolar. Where do things like personality and dissociative disorders fall into this? Dissociative disorders, you're going to sometimes get people taking antipsychotics if they have psychotic symptoms, where they break from reality. And the same thing for personality disorders. You might get some of the mood drugs, anti-anxiety, antidepressants to help with personality disorders related to mood, and you might get antipsychotics used where there are personality disorders related to kind of break from reality. Okay, so on to the four. We'll go through each of these four now in that order, the anti-anxiety and then so on. In terms of anti-anxiety, for many years there were the traditional anti-anxiety drugs that tended to act as sedatives. They're the benzodiazepines or minor tranquilizers. And we saw this before. When have we talked about these in a previous unit? I don't know if you can recall. It was in the consciousness unit. The benzodiazepines are things like Xanax, Valium, Ativan, and they are work by sedating the person taking them. They used to be the most commonly prescribed types of drugs for psychological disorders. The major problem with them is one of the benefits is they work very quickly. A major problem is they are very addictive, and so they have actually been replaced in terms of frequency of use by the antidepressants in the next unit. So if someone is suffering from one of the anxiety disorders, it is more likely now or more common that they would be treated with one of the antidepressants that we see in the next unit, although these are still used. So anti-anxiety, they use tranquilizers to kind of sedate, take the edge off the person and calm them. That's a pretty simple, straightforward explanation for those drugs. Okay, the antidepressants. That is an image from a Zoloft commercial. So there are three types: the MAOIs, the tricyclics, and the SSRIs. The MAOI drugs are monoamine oxidase inhibitors. I'm going to give you a little more information than you probably need for this just to explain that. So monoamine oxidase is an enzyme that will go around and destroy neurotransmitters. So they kind of do the cleanup work. They break down serotonin, dopamine, and norepinephrine. All three are related to regulating mood. So think for a moment, so something that breaks those down, is that an agonist or antagonist? Sorry, if you inhibit the action of that enzyme, is that agonistic or antagonistic? So that, hopefully you can figure that out. If you stop a chemical that, or an enzyme that is breaking those down, you're going to effectively increase the amount of those three neurotransmitters. So MAOIs are agonistic. Common MAOIs are marplan, nardil, parnate. Those are older and have been replaced to a certain extent by the SSRIs. They have a wide range of side effects, and so they are used less frequently nowadays. They can cause weight gain, dizziness, headaches, insomnia, sexual arousal disorders, and if you take them and then eat or drink certain things, you have a severe risk, or a risk of severe high blood pressure. So they're effective, but because of all these side effects, psychiatrists will try to limit how they're used. The tricyclic antidepressants are also agonistic for multiple neurotransmitters, so they work, but they have too broad of an effect, so also used less. So they have been replaced, at least in terms of frequency of use, by the SSRIs. And just if you need a refresher, that means selective serotonin reuptake inhibitors. You should 100% know the mechanism for how that works. If you need to go back to the neurotransmitter unit to see how that happens, I was thinking on the test I wouldn't have a short answer, but I might just put on to explain how that's done. They're very commonly known: Zoloft, Prozac, Paxil, Lexapro. They have become the most commonly prescribed drug for psychological disorders. Why are they better? They're more targeted. They just act on serotonin, and so they have fewer side effects. There are also other drugs that are SNRIs, selective norepinephrine reuptake inhibitors, but the SSRIs are the most common. They're still not perfect. When I give you the idea that they're this wonder drug, they still have side effects, and their use with adolescents is actually something that you need to keep an eye on, families and psychiatrists, because they have been associated with still a wide variety of side effects. Sometimes they don't work, sometimes they have the opposite effect, and there's actually a small but significant risk of suicide with some of these antidepressants in teens. So they're definitely common and more targeted and effective than the previous generations of drugs, but still something to be watched. The third group I wanted to talk about would be the antipsychotics. The antipsychotic drugs treat some of those psychotic symptoms of hallucinations, delusions, and bizarre behavior. So they work more with the positive symptoms of schizophrenia and other psychotic disorders. I'm not going to test you on this, except for maybe the brand names. They're phenothiazines, clozaril, thorazine, haldol, and a little lesser known, Seroquel is a more recent antipsychotic. The mechanism of the older group is they block dopamine receptors, so they are antagonistic for dopamine. There's a new generation, a third generation, called Abilify, that acts more subtly, where they actually affect dopamine release, and that's also antagonistic. So in terms of what you actually need to remember, you should remember that the antipsychotics are antagonistic for dopamine. Oh, I kind of already answered that, sorry. Side effects can be very serious. In terms of, you want to kind of limit the long-term use if you can. The main side effect that you need to be familiar with is something called tardive dyskinesia, um, which is with prolonged use of the antipsychotics, it can cause involuntary, jerky, repetitive movements all over the body, the face, the lips, the legs. Um, Tardive means late, as in tardy, and it's called that because it's late onset. It doesn't happen right away. Um, you can guess from the word that it's in there, kinesia, that it is related to movement or body movement because it sounds like kinesthetic. Um, if you want to watch a video clip of uh, 3 patients with tardive dyskinesia, um, that's a few minutes long. It's pretty interesting. Shows somebody with, I think, the facial problems and also the body movements. In it, the narrator refers to something called tardive dystonia. And it sounds like, is he saying the wrong thing, or do I have the wrong term? But the dystonia is just a specific kind of dyskinesia. Fourth, treating bipolar. The most common treatment was to give somebody lithium, which, as you know, is a chemical element from Gertie's favorite thing, the periodical table. And the use is to kind of even out the highs and lows of the manic phases and the depressive phases, especially the highs, because you can use some of the antidepressants for the depressive phase. The way it works is it affects the transport of sodium ions in neurons and muscle cells. So if you think about that, that is, sodium ions are involved in fundamental mechanism of all of the cells in the nervous system and throughout the body. So if you're altering transport of sodium ions, you're affecting every neuron at a basic level. And that's another example of how a medication can work to relieve symptoms, but has these broad effects, maybe more than intended, and you need to be careful with them. Anticonvulsive drugs are also used they've been shown to be effective in treating the manic episodes, so they're sometimes used. Pros and cons of drug therapies. The pros are sometimes they are the only thing that is effective in controlling symptoms, so they play a really important part in that role. The cons are that they're not a cure. Especially in a modern society, people and psychiatrists can turn to them too frequently. I think I would actually blame the drug companies and capitalism that they make money by getting people to take them more, so there can be an over-reliance on them. There's a risk of dependence and addiction, and what I've alluded to multiple times, that you have all these side effects, and in particular that is a function of the fact that they have work throughout the brain and the nervous system, and so they have all these unintended effects, and we don't often fully understand the mechanism by which they work, and we just know that they do control the symptoms. And then the final thing with that is they have different effects on different people, so they need to be used carefully. In terms of the other medical therapies, ECT would be a second type, which stands for electroconvulsive therapy. It was routine in the 40s and 50s. The mechanism is that you give an electric shock from one side of the brain to the other. That shock causes a convulsion or seizure, and you get a massive neurotransmitter release, and that seems to, for reasons not completely known, can improve mood or brain functioning. In the old days, you had pretty severe side effects. You would have memory loss, both of two types. The retrograde, they lost memory of stuff that had happened previous to the ECT, and anterograde, memory loss going forward, and just more general cognitive impairment. And you read in the book that the old electroshock therapy was pretty harsh and crude. There was no sedative, and people would break teeth and all sorts of other things. It was pretty nasty. In modern times, it's much less common. It is kind of a therapy of last resort. If other methods haven't been effective, they'll use it, and it's used much more in a careful and controlled way. They give about 150 volts for a second and a half, and they will give people muscle relaxants and sedatives so that it's a little more easy to take. Surgical methods have been used for psychological disorders for a while. In the 30s and 40s and into the 50s, lobotomies were common. Over 20,000 were performed. It killed some of the patients. Others were left in a vegetative state, and even in those that it wasn't disastrous, it didn't actually restore health or normal cognitive function. With the introduction of antipsychotic drugs, it went out of use. That's a photo of one of the Kennedy daughters, Rose Marie Kennedy, often called Rosemary. She was the oldest daughter, and at birth the nurse was trying to get the mom, Rose Kennedy, to wait for the doctor to come, so she told her to kind of hold her legs together and not deliver her, and Rose was deprived of oxygen for a couple hours, and as a result had IQ problems. She was developmentally delayed, and in her teen years grew kind of had these violent mood swings and became rebellious. And when she was 23, that's a picture of her at 20 when she was presented to the King and Queen of England. But 3 years after this, when she was 23, her dad, who was worried about her but also very worried about the family, and if news about her would damage his reputation and the family's prospects, because he was very ambitious for his sons, had her lobotomized, had a prefrontal lobotomy performed where surgeons went in, opened up a cut on each side, and just started cutting while she was mildly sedated, and they kept asking her questions, and they kept going until and they would ask her a question, and if she was still answering it coherently, they'd cut a little more, just a tiny bit more, and they stopped when she began to be incoherent. She didn't really know what they were doing, and she was never the same afterwards. Reduced her down to kind of the level of a 2-year-old and could not take care of herself anymore. And so that was actually a family tragedy that the dad did. He's not really a good man. And she's maybe one of the more famous people that had the lobotomies. They went out of favor. And now surgical techniques, again, like ECT, are rarely used, but as a last resort. The book talked about deep lesioning, where you'll get an MRI, it'll place an electrode that'll be placed in very carefully, and then they will kind of use it to damage the brain cells in a very small, contained area. Still pretty radical technique because you don't get those brain cells back. But used much more controlled fashion than lobotomies were. The book also does a nice job talking about a couple of emerging techniques either magnetic pulses or low amp currents. Um, RTMS is repetitive transcranial magnetic stimulation. TDCS, transcranial direct current stimulation. You don't really need to know much about them, but you should recognize them, and the idea that they are um, transmitting these pulses through the brain, and again in a much kind of more low-level fashion, a little more controlled and subtle than the older methods. So what do you need to remember from this? You need to remember that there are 3 types of biomedical therapies. The evolution of medical treatment, we're getting a little bit more subtle and careful with it, although still a search. You need to know the kind of general pros and cons of drug therapies and the mechanics by which they work, and then the specific drug therapies for the 4 that I talked about, and then the other methods. And in terms of terms, I'll just list a couple of things you should be familiar with. Out of these, I think SSRIs, tardive dyskinesia, and ECT would be the biggest. That's it. A little bit long, but hopefully interesting, and I will post on Google Classroom some expectations for the test. See you Monday. Bye.